Hello and welcome back. AEMT, Chapter 37, Head, Brain, Face, and Neck Trauma. So this chapter varies a little bit from the EMT curriculum in that it goes more into actual facial injuries as well as the whole head and neck, okay? So this is part of what I like about this. I also think that this one gives, again, a few better descriptions of certain things. So here we go. I'm going to turn my camera off while I do this. All right, so here we go. So a little review, our skull, part of the skeletal system and certainly provides protection for the brain. Our skull, right, our cranium is the brain bucket, the whole main piece of what we think of our head, which are made up of different bones. I mean, you think about your arm, that's made up of different bones. Excuse me. Well, so is your cranium. We have cranial bones and we have facial bones. And we're going to see some slides here of that in a minute. Basal skull's floor of the bone, and about 85% of the brain of that space is made up of brain. The rest of it is blood and CSF. So the brain itself, the medulla oblongata, right? Watch The Water Boy, and you know what the medulla oblongata is for. And if you don't get that quote, shame on you. Go watch The Water Boy. Bottom of the skull, opening the foramen magnum, and the spinal cord, it comes off the brainstem at that point. We have different linings with the cranium, the skull itself. Then we have the dura mater, which is the outermost lining. It provides attachment points to the skull as well. The arachnoid matter is the middle lining, and our pia mater is the inner lining right against the surface of the brain. Now, the brain, CSF, cerebral spinal fluid, serves as a cushion, and there are 3 layers of meninges, those linings, okay, that we talked about. 3 parts of the brain: cerebrum, cerebellum, and the brain stem. So the cerebrum is what makes you you, right? Your cognitive function, how you think, how you put things together, how you think and react to things, as well as sensory and motor. The cerebellum is coordination and equilibrium. That's pretty important. So if you think about damaging your cerebellum with a stroke or with head trauma, and you have equilibrium issues, that would suck. And then our brain stem, which is made up of the pons, the midbrain, and the medulla oblongata, autonomic, right? Your vital signs. Injury to that, we have vital sign issues, which can lead to death of our patient. Our neck, besides having the spinal column, we also have our airway stuff, right? Larynx and trachea. We also have major blood vessels, our carotids that feed blood to the head, and our jugular veins, both internal and external, that bring blood back. When we talk about jugular vein distension, we're looking at our externals for the most part. Okay, so any injury in the neck, significant bleeding. We'll also talk a little bit about air issues with those, and of course, seizure, coma, death. Now, facial bones. The mandible, which connects up here at the temple, is the only bone in the brain, in the skull rather, in the head, that is supposed to move. Anything else is a fracture. So we have our orbits, or our orbits are made up of a bunch of little bones, both facial bones and kind of cranial sinus type bones. Little opening in the back for blood vessels, nerves. There's attachment points for muscles so your eye can move. Maxilla is your upper jaw. Orbits, zygoma is cheekbone. So maxilla, zygoma, and frontal bone of the skull make up that outer rim of the orbit. So when we're assessing patients, we want to, like I put my hands on the side of their head and I put my thumbs together and I push, I go right with my right, I go around the orbits with both thumbs, both high and then around low. Then I come down the nose. I feel across that portion of the maxilla where the teeth would be, and then I feel the mandible while I'm there. So 14 of them. Most are removable, right? Protection for the eyes, protection for the airways. Significant trauma, besides the worry about brain injury, you also have to worry about your A's, your airway, because there's a lot of vessels in there and a lot of issues with bleeding and airway concerns. The eye itself, you can see artery, vein, and nerve coming in. You do not need to study this. The biggest thing with the eyes, in my mind, are vitreous humor is the fluid that makes the eye an eye, right? If you have a puncture of the globe is the eye itself, the muscle and the tissue that makes up the eye, and you have vitreous humor that leaks out, pretty much you're done, okay? Anterior chamber, the lens, right? The iris. So the iris is that colored muscular portion of the eye that constricts and expands, that gives you pupil size, okay? Cornea is in front of all of that. Corneal abrasions, right? You get a scrape. The docs put a little bit of dye in the eye and they look at it with a blue light, and if they see what looks like cross-hatching, you have a corneal abrasion. Not a big deal. Here's some antibiotic ointment. You can see muscles that attach inside the orbit, allowing, in this case, it shows a cross section, so up and down, but also has lateral movement. Orbital fractures are a concern to us because these vessels can get caught in the cracks, and now you have no blood flow to the eye or back from the eye, as well as nerve involvement, or the muscles themselves can get stuck in those cracks as well. So when you're checking eyes and you're checking pupils, besides shining a light in to see if the pupils react, or the iris, that you want to have them move their eyes left and right, up and down also. Somebody gets punched in the eye and they can't move that left eye. Maybe they can move it up, but they can't move it down, or they can't move it to one side or the other. Then you have some entrapment involved. The eye, globe, spherical, about an inch in diameter. The outer layer, the white, is called the sclera. And then the cornea is that clear covering over the front. Iris, the colored portion, it's the colored part. And it dilates or constricts to change the size of the pupil, which allows more light in or restricts more light depending on the conditions around them. And the lens focuses the light onto the retina, so that the retina is like the movie screen, and it flips itself up. That image is flipped upside down in the process, and your brain and ocular centers take that upside down image and convert it so that you're seeing it right side up again. Retina, light sensitive optic nerve. It's inside the brain, and the impulses are interpreted on the retina as an image. And we have two fluid cavities, the aqueous humor and viscous humor. The orbit, cup-shaped, provides protection for it, and muscles attached to allow movement. Now, signs of injuries to the eyes and to the head itself. Altered mental status, that makes sense. Bleeding any place, substantial swelling or discoloration. Substantial, that's kind of a objective statement, isn't it? To my idea of substantial hematoma to the back of the head might be different than yours. Pain, loss of function, dizziness, headache, nausea, vomiting are all very common complaints with head injuries. And we're going to do our scene size up for safety and mechanism of injury, right? As I approach, what do I see, hear, and smell? Do not get distracted. Remember, ABCs come first. So, you've got a big laceration on the head, like a scalping type injury, or an incomplete scalping, which happens. Oh my God, well, ABCs. But remember the C part of that, right? Do I see any significant bleeding? Okay. ABCs. And keep in mind the fact that they can have issues with vomiting coming up that they don't have yet. Their mental status can decrease, which is going to provide some mechanical obstructions, as well as maybe now they can't clear their airway to get rid of the vomit or drool. Severe cases. So severe cases, they should be intubated. We're finding that more and more of these people with just diminished altered mental status probably should be intubated because it protects their airway. Okay. We can also control their ventilatory status that way. So you're looking at this patient and you're like, ugh, then you probably want to start thinking about a medic. If you have any airway issue, you have to go to the closest medic or the closest ER. Okay. Open wounds, direct pressure, hemostatics are great. If they've got that big mechanism of injury, or you look at them and you know they're hurt, you got to do a rapid trauma exam. Okay. Focused exams are okay with isolated injuries, right? They bump their head on a cabinet and they have a 4-inch laceration and they're bleeding like a stuck pig. You don't have to do a rapid head to toe exam, right? You can, from the collarbone up, the clavicles up. Okay. Isolated injuries. Now, vital signs and sample history and baseline vitals. That means on the scene, in the house, in the car, in the road, whatever. Baseline is baseline. If you wait 10 minutes, you're behind the curve. You may not be seeing the changes that are already taking place. Critical patients every 5, stable every 15. And anytime you have anything change, like they don't answer a question appropriately, or they don't answer you, or whatever, go back to your ABCs, but always remain alert for signs of shock, right? The compensated shock first, right? The pale skin, the tachycardia, the tachypneas, okay? But with normal blood pressure, still can be shock. Scalp, people go, oh, it's just a scalp wound. We'll just, scalp wounds bleed. And if I'm at 5'11" and I have 5 liters of blood in my body and I lose 500 cc's of it through a scalp wound, guess what? That's still 10% of my body fluid, of my blood rather. So you got to control scalp wounds. A year-old toddler who loses 50 cc's, he's only got 500 to start with, right? So anyways, now scalping injuries. Think of scalping injuries, you think of the Westerns and you think of stories from the Indian Wars, but a guy this spring who fell off a dock, putting his dock into the lake, fell into the rocks and had a plate-sized avulsion, incomplete scalping. I mean, the entire top of his skull was exposed, right? So large flaps. That's not just the skin that's, you've got all kinds of vessels underneath it, in it, all the way around that plate-sized laceration. You've got this disrupted vessels. So, my BLS crew had a pressure dressing as best they could on top of it, and wrapped it like with 1,400 miles of cling, and it was soaking through. So, lift the flap up, start throwing quick clot under it, quick clot around the edges of it, flap down, multi-trauma dressing on top of that, and then pressure. Held pressure with my hands while we wrapped that, as tight as we could without, of course, cutting off circulation to his head. But you've got to address scalp bleeding. Now, closed scalp injuries, blunt trauma. That's your bruises, your hematomas, your contusions, right? You got to think about what's underneath that. And, you've got a big egg on the head, put an ice pack on it. So types of skull fractures, linear non-displaced, right? That's your tree branch. But everything, when you feel it, you don't feel it. It shows up on an x-ray. Depressed, you're feeling around the head and you're like, ooh, that's soft and squishy. Well, is it a bruise that's soft or squishy? Or when you push around the bone area, you can feel bone, but when you move into the middle of it, you don't feel the bone anymore. You're going to have open and you're going to have impaled objects, which of course you want to stabilize in place. So that skull, thick plates of fused bones, they are not fused at birth, right? Those lines in between the occipital, parietal, frontal, and temporal bones are not fused initially. That allows that baby to come out through that small canal and have that cone head, which over the next day or so goes back to normal. Then they start to fuse after that. ABCs, ABCs, ABCs. I cannot stress that enough with these folks. And certainly you need to think about TBIs. You need to think about cervical spine. So TBIs we'll talk about in a few minutes. Our linears, again, we're probably not going to feel it. It shows up on the x-ray. Depressed, pushed into the skull, which means also potentially direct trauma to the brain tissue. Closed skull fracture, the scalp remains intact and the brain is closed to the outside air versus open. Immobilized, impaled objects. So basal skull fractures, the base or floor of the skull. And what you will find with those, this is a patient that when you look for, do I see any bleeding or clear fluid coming from the ears, nose, or throat, right? You can have a nosebleed with a head injury, right? You banged your face as well, right? But you start to see clear fluid coming out of the nose or clear fluid from the ears or blood from the ears. You got to think about the fact that the brain has some bleeding and swelling going on, and it's a very compact system with no space for expansion except out, okay? So CSF. Raccoon's eyes, bruising around the eyes. I mean, that makes sense, right? Two black eyes, you look like a little raccoon. That is basal skull fracture. And battle signs, bruising behind the ears. Now, some people will say, well, these are late signs. Well, kind of yes, kind of no, in that depending on how bad that injury is. So you can have significant injuries and have those right away, or it can take up to days to evolve. Okay, so again, the skull does not expand and pressure within starts to climb based on either swelling or blood. Primary brain injury is when they take the blow. They fall off their skateboard and smack their head. However, because of, let's say, the pressure climbs and the blood pressure can't overcome that, therefore the blood flow to the brain diminishes. They can then have ischemia and hypoxia and strokes because of that. And the swelling within the brain can actually damage brain tissue also. That would be a secondary injury. Now, intracranial pressure. Within our head, we have pressure within that system, right? It's a closed system, and you have tissue and CSF and blood. Your blood pressure needs to be greater than that pressure in order to perfuse the brain. So I think of it this way. If you have a milkshake and you have a straw and you're blowing into that straw to make bubbles, right? You're trying to blow air into the milkshake. You are perfusing the milkshake. When that milkshake, you have a McDonald's milkshake and it's kind of thin and it's kind of easy to blow air into it, that's normal pressure. When you have a milkshake that I make at home and that bad boy is super thick, that's increased pressure you're blowing against, it takes a lot of force to get air into that, okay? So as it climbs, that's your super thick milkshake, and it takes more pressure. So as intracranial pressure climbs, your blood pressure will climb with it, okay? As that pressure climbs, you also have less brain function. You can certainly have projectile vomiting. And when I say projectile vomiting, I mean, like I'm sitting at my counter right now, and if I projectile vomit, I'm going to hit the kitchen door. Okay. You know, they're on your stretcher and they're hitting your back window and your door, you know, the window and your back door of the ambulance, whether they're conscious or not. So airway. Headaches, super common. Altered mental status. Initially can just be anxious, right? Then confused. Then they can be aggressive, combative, unresponsive, okay? Unequal pupils or blown pupils. Cushing's reflex is that increasing blood pressure, but the carotid baroreceptors go, oh crap, my blood pressure's spiking, I better drop my heart rate, decreasing heart rate. Now, Cushing's triad are three things. So Cushing's reflex is pressure, pulse, and when you add in an irregular breathing pattern like ataxic or chain stoking, that's Cushing's triad. At that point, you know the brainstem is being pushed into the foramen magnum. They are herniating their brainstem. With that herniation, you will also get posturing. So the top one is decorticate. If you look at the fingers, hands, wrists, and arms, they're in towards the core, decorticate. Okay? The feet are curled in towards the core. Now, decerebrate is away from. So you can see the hands and wrists are extended out, right? They're back away from the body. Decorticate tends to be second decerebrate. You see decerebrate and then they go decorticate, right? So they're pointing in towards the injured part of the brain. So that increase in blood pressure, right? So you've got increasing intracranial pressure, which causes an increase in blood pressure, which makes that intracranial pressure worse also, which makes the injury worse. So how do they fix that? Well, they go in and they drain it. They drill, they put shunts in, they drain. It takes a neurosurgeon to do this. Not every trauma center has neurosurgeons, right? Let's say Wentworth Douglas and Parkland in Derry, New Hampshire. So two New Hampshire level 3 trauma centers might be really good at stabilizing normal multi-systems trauma, but they don't have neurosurgeons, right? I don't know what Concord has for neurosurgeons, but I do know that Portsmouth has phenomenal neurosurgery. They have a neuro ICU. The helicopters in the area fly head injuries into Portsmouth. So when I'm looking at a trauma center, because I have a head injured patient, can I take my patient to Portsmouth? If the answer is it's too damn far away, then I'm going to put them in a helicopter, okay? But if, am I going to drive past Wentworth Douglas to go to Portsmouth? Yeah, because they have the neuro, okay? So you've got to take them to the right place. So herniation is the foramen magnum is the biggest opening in the skull. So that's the one that the pressure is going to try to squish the brain out through. So herniation. A herniation is just moving an internal body part through an opening that it's not supposed to go through, whether it's an inguinal hernia in your groin, or whether it's an umbilical hernia in your belly button, or whether it's brainstem herniation. So that signs of herniation, the Cushing's triad, pupils are either blown or one's blown and one's constricted. Altered respirations, well, yeah, no kidding. That's part of the triad. Trismus is the jaw locks shut. Oh, great. And now they're going to projectile vomit, right? These people need to be intubated. You need RSI, and you need to paralyze them and have them intubated. Posturing. So initially, decorticate or decerebrate may not be obvious until you poke them with an IV, and then boom, they posture. okay? And it may go away, and then they posture, and then it goes away, and then they just posture, okay? So decerebrate, rigid extension, decorticate, rigid flexion points towards the injury. So the factors that worsen cerebral edema and ischemia: intracranial pressure, rising blood pressure, right? Now, what we would like to do is keep these folks in a normal kind of blood pressure. And what I mean by that is if they are shocky, they need to have some fluid. Boluses of 250 to 500, and we need their mean arterial pressure. We'd like to have at least 65, and their systolic, if that's what you're going by, of at least 90. Okay. Excess carbon dioxide. Now, 35 to 45 is normal. That's what we want our TBI patient at. If we have an unresponsive trauma patient and we're bagging them, we want 35 to 45. If we are seeing signs of herniation, we want them closer to 35. 30 to 35 is okay. Do not let them get below 30 because low CO2 causes vasoconstriction. That helps a little bit with intracranial pressure, but when you get to 25 for CO2, their mortality rate climbs 700%. Holy shit. Why? Because they have a massive global stroke because you've cut off blood flow to the brain. We also need to make sure they have a normal blood glucose. Don't forget, they could be unconscious because their blood sugar is 40, right? They can have a TBI and be hypoglycemic. Why did they crash their car? Why did they fall off their motorcycle or bicycle, right? Oh, because their sugar was 20. So we want normal blood sugars. We want normal CO2s. We want safe blood pressures. Now, neurological exam, right? Altered mental status. What is their responsiveness? What is their mental status? How are their pupils? Are they equal and reactive to light? Do their pupils move back and forth together appropriately, right? When you look all the way to your left, your eyes should move smoothly to the left and stop. All the way to the right smoothly and stop. So horizontal gaze. Now, nystagmus is when you go to the left and your eyes bounce at the end, all the way to the left, they bounce. And you go all the way to the right, they bounce. When I see that, in my brain, I hear click, 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 click. The guys don't make that sound, but that's what my brain transmits it as to me. This is altered neurological function. Where do we see this? Oh, we see it a lot in police officers, right? They do this for intoxicated patients or people who might be intoxicated because they are neurologically altered. So if we have a patient who has hit their head and they're stone sober without a drop of alcohol in their system, guess what? They can still be neurologically altered and have horizontal gaze nystagmus. Look for neurological deficits. Can they discern sharp and dull in their toes? Can they tell you sharp or dull in their calves, sharp or dull in their thighs, sharp or dull in their fingers, hands, forearms? Okay. Now, consider restricting cervical spine motion, right? So until proven otherwise, manual stabilization of C-spine. ABCs. Oxygen if needed, absolutely. This is not American Heart Association coronary artery disease. This is trauma. Trauma patients need some oxygen. If you have an altered, unresponsive, whatever head trauma patient, put them on a non-rebreather. Ventilate them if normal, if needed. If they're not combative, I want a couple of IVs in these people because A, I might need glucose. B, I might need IV fluids. And C, these people might need resuscitation. And D, they might need sedation by a paramedic because now the guy's combative and kicking the shit out of you. If you've already got the IV in, that's great. The medic can drop some Versed and Haldol, or they can draw up some ketamine, boom, or some etomidate and the succinylcholine, or ketamine and rock, whatever, and RSI them. We don't want to be screwing around on scene with these folks either. Right? Normal body temperature, trauma patients get cold. They have difficulty maintaining their thermogenesis, right? Their temperatures. A degree or two difference in a trauma patient increases mortality significantly. Why? Because it increases oxygen demand significantly. So concussions. I'm going to open my camera for a second. Now, I want you to take your hand like this and your fist like this and punch it. So what you get is some pain, some zinging, some pins and needles, some numbness, right? But you look at it and go, there's no bruising, there's no cuts, there's no swelling. That's a concussion, okay? My brain is concussed. My hand is concussed. So, post-concussive syndrome, headaches, memory problems, depressions, right? Since 2005, 2006-ish, with the NFL and the military with Iraq and Afghanistan, we have found that concussions really do have some fairly significant issues. You know, when I was 18, I broke my neck in a car accident. I also had a hellacious concussion. Horrific headache that lasted like a couple of days. And then I had a lot of problems with my memory. Not long-term was fine. But I remember sitting in, see, long-term memory now is fine, short-term still sucks. But fifth period, my senior year, last semester was human growth, was independent living. Teach you how to move out of your house because nobody wants to live with your parents once you're 18, and how to like find apartments and all that crap. But I remember sitting in that, and my next class was math, only I couldn't remember it. I'd be sitting there, I'll be like, man, oh man, oh man, where am I supposed to go next? And I kind of started looking around, and my classmates and my teacher figured this out pretty quickly that I was lost. You know, and one of them finally, Kevin, what, you're going to math next? Math. Oh yeah, thanks. I appreciate that. I'm going to algebra. Okay. I mean, geometry. Okay. Then I kind of look around a little bit more, and they go, Kevin, go across the hallway, go up the stairs, go straight across. That's your math class. Oh yeah, thanks. But I had my best grades of my senior year that semester because I had to concentrate more and study more. So I had to write everything down, and which I'd never done in high school. But that's pretty significant. And this went on for months. Mood swings. Yeah, so concussions, people go, oh, it's just a concussion, you'll be fine. The worse the concussion, the worse the effects are down the road. The more concussions you have, the worse they are. I remember I was like 12 years old. I had a bunch of concussions by that point, you know, motorcycles, bicycles, ice skating, you know, just living. And I remember I banged my head once, got knocked right out cold playing hockey because we didn't wear helmets back then. And my pediatrician, my mom took me to the pediatrician because that's what we used to do back in the 70s and 80s. And he said, you know, you got to relax. You got to stop some of this crap because if you have another concussion, you could be a vegetable. We knew this back then, but we're just kind of figuring it out in 2005 and 6 again. So anyways, we can certainly have concussions with other TBIs as well. Now, coup contra coup, you take a blow to the forehead, whether it be the rock or whether it's a steering wheel, and you can have damage right there. But the brain also shifts forward and or backwards. And you can see these blood vessels, you can have shearing of these vessels, which causes bleeding. And also you can have impact damage here, and the back of your brain impacts here. So you can have bruising, swelling there, bruising, swelling here. You can have bleeding all the way around it. All right, so coup and contra coup. Now, specifically, contusions are just, they're bruising, right? And you have swelling in the brain. Altered mental status, weakness, seizures. You get to seizures with TBI, we're in trouble. Altered respiratory rates and patterns. These guys are in bad shape. Speech, bradycardia, all these things, right? We're assessing for these. Nausea, vomiting, oh, trismus, right? Jaw locks and you're vomiting, airway's gone. Now, this diffuse axonal injury is all those little blood vessels. Well, blood vessels aren't the only things that shear. Remember, an axon is the nerve cell, right? So and these nerve cells aren't a single circular cell. They have, if an axon was an inch long, we know they're not, they're microscopic, but if it was an inch long, the first eighth of an inch would look like a spider web reaching out. Then partway back, you have your neuron and your cell body. And then you have this long extended kind of, I think of it as a tail, down to a smaller set of spider webbing, right? And that like little tail is kind of like an extension cord. It's got protective material around it called a myelin sheath. Well, in that section, if you shear that, you lose the function of that cell. So now think of diffuse, meaning massive shearing of the axon, okay? You end up with basically like lifelong coma, okay? Shaken baby syndrome caused that. These folks don't do well, okay? So it could certainly be a back and forth. Oh, it's just a whiplash, but why are they in a coma? Right? There's no bleed, and so here's the other thing with this: there's no bleeding and swelling on the CAT scan. Why are they in a coma? Because of this. Okay. So, when we talk about some different injuries, right? You fracture here, you can tear this artery. Gives you this epidural hematoma. So the dura mater is the outside lining of the brain, and it provides some attachment points to the skull. But between the dura mater and the skull runs this middle meningeal artery. And if you tear that, so you could have an epidural any place. But epidurals tend to be large vessels that cause large immediate impact. And a lot of these guys are the ones that are already unresponsive, posturing or seizing, or they're just combative as hell and they're going to be unresponsive, right, on scene. Subdurals. So sub means below the dura mater, and these tend to be smaller vessels. These smaller vessels, these subdurals can actually show up 6 to 8 weeks later. Right? So when we talk about history of the present illness, sample history, right? E, events leading up to it. If all you do is say, so with this really bad headache that you've got, this migraine that you've got, first off, do you have migraines? No, okay. What were you doing when it started? Just sitting here on the couch. That doesn't answer your question. You need to start asking with these headaches and neuro symptoms, hey, in the last, 6 to 8 weeks, month and a half to 2 months. Remember, people are horrible with time frames. Hey, in the last 2 to 3 months, have you had any accidents? Have you fallen down? Have you hit your head? Have you gotten beat up? Have you been in any car accidents? Now that I think about it, I don't know, 2.5 months ago, right? I missed the last couple of steps and I banged my head on my desk. Did you get knocked out? I don't think so. Okay, guess what? They have a subdural head bleed until proven otherwise. So where do they go? Trauma center. Intracerebral, so just down inside the tissue. Now, epidural, as we said, between the skull and dura mater. Subdural, between the dura mater and the arachnoid. Subarachnoid is below the arachnoid mater and the pia mater. The pia mater is the inside lining. These tend to be larger vessels also, by the way. and then within the tissue itself. So these epidural, subdural, subarachnoids are kind of, not for me, but they're kind of easy to fix because they're accessible, right? All they got to do is a couple of holes, do a couple of linings, a couple of shunts, a couple of drains, and you know, if they get to it fast enough, the patients do okay. Intracerebral, oh man, so that's going to depend on where in the brain tissue it is. Can they get to it or not, right? Injuries to the face, frightening, and certainly scary as far as disfiguration and vision issues. If you're freaking out, they're going to freak out. Biggest issue, airway. Okay. Now, here's kind of a nice little trivial thing. I mean, they're not trivial, they're very bad, but Lefort classification of fractures. So if you break your maxilla here, your upper jaw, as you think about it, is kind of free floating. So when you're palpating, you can feel this, right? You wiggle that maxilla back and forth, it should be intact and stable. Lefort 2, the maxilla and the nose feels like it's floating. Lefort 3 is temple, nasal, temple. The entire faceplate feels like it's moving, right? So this, by the way, is a very easy patient to maintain airway in because you can literally just kind of lift the entire face up and slide your airways in place. Easiest patient I've ever intubated. Lefort, so slight instability, right? Lefort 2, maxilla nasals, certainly painful. And also, usually with the 2s and 3s, we get some CSF leakage, okay? Normally, nasal bones by themselves are not, you know, no means no, and you get punched in the face and you break your nose. The issue to that is just blood, okay? Letting them lean forward and either spitting blood, letting it drain, whatever, okay? Orbital fractures, you gotta have them move their eyes. Move their eyes right, move their eyes left, move their eyes up, move their eyes down. Make sure that they have good movement of the eye of the eyeball itself. Ooh, subconjunctival hemorrhage. So punch in the eye or a stick in the eye, whatever. You can see he has a ton of bleeding inside the outer layers of the eyes. Okay. Treatment, ice pack, and ideally, I don't know, if I was close enough to an eye, like Mass Eye and Ear, I'd want to go to Mass Eye and Ear. Now, the ER can certainly transfer somebody to Mass Eye and Ear. You can walk into Mass Eye and Ear's ER and be seen off the street. They do have an ER. One of my buddies got hit in the eye with a Nerf gun implement from his grandson. Walked up and shot him in the face with it, and he tore his retina. And so he called the ER where he works and said, "Hey, what do you?" He goes, "Just drive to Boston. You know, go direct into the ER." And he went into the ER, and they assessed him, and that was at like 11 o'clock at night. And they gave him a place to lay down. And at like 6:30 in the morning, the eye surgeon came in, did everything, and he was on his way home by lunchtime. So that's what I would do if it was me. So eye injuries, blunt, penetrating, and chemicals. Detached retina, the force gets applied to the eye great enough to cause that separation of the retina. It is truly an emergency. You can lose your sight permanently with that, okay? Dark areas within their vision. So I want you to look at my face. Tell me what you see, right? Yeah, some ugly son of it, right? But do you have any areas in your vision that look darker than others, right? Do you have any areas in your vision that don't look correct to you? Penetrating trauma, right? Immobilize it, cover both eyes because that left eye is going to move and the right eye is going to move with it. So you should, close both eyes. Don't remove stuff. Don't try to put an eyeball back in. You'll do more damage than good. Cup and dressing over it, certainly. Cover both eyes and transport immediately. So chemical burns, flush as much as you can. Now, look at this. He's got a normal pupil here, and this one is big and large, right? So the chemicals already affected this eye. So I would want to flush his eyes out with a ton of water. Put him right under the sink, right? He's at his house, I've done this a bunch of times. I'll lay him right on the counter, put their head in the sink, and just run the faucet right here. If the left eye is the only one affected, I'll tilt the head to the left and run the water here so that I'm not running the chemical across the other eye. Red, cloudy, swelling, blurred vision, pain, certainly burns around the eyes, flush them. If they've got contacts, I have them take the contacts out because I don't do contacts. I don't have them. Right? I'm going to have them take them out because remember, even if you flush the eye out with a contact lens in, the contact's affected and there's chemical caught between the contact and the eye. Minor bleeding is not a life threat. To the ears, so external ear injuries are where we tend to see, or like, you know, the kid jammed something into his ear canal, that's all right. But if he banged his head and he's got blood coming out of his ears, that we're worried about. Adults' teeth, you get teeth knocked out, we want to take them with us. If you can, you're in the house or you're at their house, you can put teeth into a container with some milk in it. That's what they recommend, and take them with them. Sometimes they'll put them back in. Neck injuries. This is a good hole. Besides this kind of open area here, which isn't that big a deal, this is, okay? So there's penetration here and penetration here. We need to worry about arterial bleeding, and we also need to worry about the jugular veins because the atmospheric pressure in the jugular vein is less than in the air. And so you can actually have air sucked into the jugular veins here. So one of the jugulars runs here. So we're kind of safe with that one, but, and you can have large air embolus. So air emboli act just like a clot. You get a big air embolus in the lungs and you restrict blood flow through the pulmonary vasculature, you can have obstructive shock, right? If you throw one of these air bubbles into the coronary arteries, you can have an MI and you can have a stroke. Okay, so we want to put an occlusive dressing on them. We want to put bandaging on them. We want to try to apply isolated pressure to this. Don't, don't put a tourniquet on them, okay? Cervical spine, blunt or trauma, blunt or penetrating. We know that you can have paralysis, you can have paresthesias, you can have all sorts of neurological injuries and compromise with this. With swelling and bleeding, that can be big enough to impair blood flow, to obstruct the trachea. You're not going to do that with a hematoma, but above the epiglottis, you can certainly have enough swelling to close that airway off. Okay, so immediately gloved hand over the opening in the neck, and then have somebody else prepare some sort of an occlusive dressing for you. Damage to trachea or larynx, right? You take a blow across the neck, you can certainly fracture the trachea, and that can certainly cause you some ventilatory airway problems. All right, so chapter 37. You know, my EMT one, the C-spine one is a little more in depth on this as well, but they go hand in hand nicely. So I will see you at the next class.